Welcome. Thank you for joining us. Our last presentation of the conference is a duo that brings us back to our focus on our patients. Dr. David Michalek and Ms. Erin Givens. Dr. Michalek is a clinical psychologist and clinical director at the Child Development Center at Nationwide Children's Hospital and is currently clinical associate professor of pediatrics at the Ohio State University College of Medicine. Erin Given is a clinical research coordinator with the NCH Child Development Center. They will be discussing behavioral characteristics of patients from the NCH Multidisciplinary PWS Clinic. Please join us in welcoming them.
Hello, everyone. Thank you for the invitation. Let me get my screen share on so that I can pull up our slides. I think this should work. Okay. Okay, great. I think we're good to go. Yeah, thank you for the lovely introduction. Again, my name is David Michalek. I am a psychologist with Nationwide Children's in Columbus, Ohio. And the title of our presentation is Ongoing Psychological and Behavioral Evaluations in a Multidisciplinary PWS Clinic. And I'm here with my co-presenter, Erin. Let her introduce herself a little bit more.
Hello, everyone. My name is Erin Given. I work at Nationwide Children's Hospital, and I've worked with the Prader-Willi team for about 2 years.
And a theme that I'd like to draw through our entire slides is that there's lessons that we've learned in doing behavioral and psychological evaluations, and there's lots of things Erin and I and our teammates are still learning. So this is certainly a project that is in process, and we're learning as we go. So let me first tell you a bit about our clinic. So the Nationwide Children's Hospital Prader-Willi Syndrome Clinic is housed in the Department of Endocrinology. It's staffed by a wonderful group of people from many different disciplines, and I'll tell you a little bit more about them later. And we certainly see kids from Central Ohio, but also all the other kind of four corners of Ohio and other states. So we're fortunate to be able to have a clinic with folks dedicated to this population. We meet twice a month, and I'll be honest, it's I look forward to those Fridays when I get to go to PWS Clinic. And for our project, we want to discuss some data that we've been gathering. So we've been gathering data in 3 areas. The first is cognitive development of kiddos in our clinic. The second is behavioral presentation, according to what their parents are telling us. And the third is overlap between Prader-Willi syndrome and symptoms of autism spectrum disorder. And again, the highlights that I want to draw through every slide is things that we've learned along the way and things that Erin and I are still learning. So let me turn this over to Erin to tell you a bit about the demographics in our little project.
So here are the demographics for the children that we have tested so far. So as you can see, we have an even split between males and females. We've split our age range between young children, adolescents, and beyond, and school-age children. We do have more deletion cases than UPD cases, which is consistent with the Prader-Willi population.
And this group here is not the entire clinic population that we see. There's lots more kids and families that we see in this clinic. This is just the data we have gathered up to date. So let me jump in. The first area is we've been able to do some assessment of cognitive skills in kids with Prader-Willi. We have been using a tool called the Stanford-Binet Intelligence Scales. It's a very commonly used assessment. It's used all across the country in school districts, clinics, practices everywhere. The nice thing about the Stanford-Binet is it has an abbreviated measurement. So you can do 2 what are called subtests, one of which is for nonverbal fluid reasoning, which is basically analogies and patterns and figuring those out, and what we call verbal knowledge. So that would be identifying and defining words and also some pictures for the younger kids. When you do the brief Stanford-Binet, it takes about 5 to 10 minutes approximately. And the Stanford-Binet gives you a standard score, all right? So a little bit of statistics here. An average standard score is 100. Any standard score that's about 70 or less indicates there's a substantial area of delay. So Erin broke the age groups up into those 3 areas. And you can see the standard score we're getting for each area is falling below the 70 mark. So that's pretty consistent with what we would expect for kiddos with Prader-Willi syndrome, because we know all folks with Prader-Willi have some cognitive and learning difficulties. So again, back to our theme, what we've learned so far is that the results we're seeing in clinic is quite common to what we'd expect from the literature of folks with Prader-Willi. But what we're still learning is the Stanford-Binet the best assessment tool to use? The Stanford-Binet starts, for example, at age 2, and we have infants in our clinic. So Aaron and I have been thinking about, can we use an assessment tool for much younger children? So that's something that we're still trying to figure out, is this the right tool to use? Another neat thing we've been able to do with the cognitive scores we've been gathering is measure a few particular children's scores and their progress over time. So Erin was able to pull out 3 kiddos. You'll see them listed there, and she pulled out intervals of giving the same assessment. The interval is about 10 months to 12 months. It really depends on lots of factors, like when the family can make it in. So we haven't standardized that yet. But as you can see, the first child, it's a she, her scores went up. The other 2 kiddos stayed about the same. So what we've learned, again, I think is positive, is that we can measure the cognitive skills in kids with Prader-Willi over time. But what we're still learning, of course, is where there's variability. So why do some children's scores improve? Why are some children's scores relatively stable or even decline? And what are the right time points to evaluate at these intervals? So that's the first little bit of data we wanted to share with you all, as we've been measuring the cognitive skills of kids with Prader-Willi in clinic. All right, moving on to the second area is behavior. So now we're looking at the frequency of challenging behavior in this population. So we've been asking parents to complete an assessment tool called the Child Behavior Checklist, or CBCL. Again, it's very commonly used in clinics and schools all across the country. There are 2 versions of it, a younger child version and an older child version. We chose to only highlight the older child version. The younger child version didn't really have a lot of interesting data in it. And the Child Behavior Checklist gives you T-scores, so a bit of different numbers here. With T-scores, an average is 50, and anything that's clinically significant would be 65 or higher. What that's telling us is if a parent rates a child at about 65 or up, there's a concern. So there's more challenging behavior in that area. So Erin was able to bold for us the areas that tended to pop higher or getting close to high for this age range. So as you can see, 2 popped up in the first little table. Thought problems, what that's gathering is the obsessions that some kids with Prader-Willi have, and the second is aggressive behavior. So some kids that get frustrated quickly and overwhelmed fast. Some more numbers here from the CBCL. 3 other areas popped up clinically significant. One is social problems, and the second and third would be conduct difficulties and defiant and oppositional behavior. So that stubbornness that some parents are reporting to us with their child with Prader-Willi syndrome. So far what we've learned is that there are some behavioral, social, and obsessional challenges in kids with Prader-Willi in this age range. Again, the younger children, we didn't really find a lot. But what we're still learning is, the application of this. What do we do with this information? So potentially, if we see some of these numbers high that I can see, do I offer the family some anticipatory guidance about some behavior strategies to kind of manage maybe some of the oppositional behavior? Or if some kids have had a real significant challenges with their behavior, should we make a referral to another professional, for example, psychiatry? Our clinic here, we're fortunate, we have a psychiatrist who's not part of clinic, but sees a lot of our kiddos. So that's the second area of behavioral assessment we've been doing, is looking at the frequency and intensity of challenging behaviors in this population. All right, the third area of kind of data that we've got. So we decided to look at the overlap between Prader-Willi syndrome and symptoms of autism spectrum disorder. Obviously, you could write a thesis or a dissertation. Maybe that's been done out there. I'd love to see it. Send it my way, about the question about, is Prader-Willi and autism, do they overlap? So we decided to use a tool called the Social Communication Questionnaire. And it's a screening tool for autism. So we use it at the clinic Erin and I work at all the time. It's a simple yes/no checklist, and it's a cutoff score. So if a parent reports a cutoff score at 15 or higher, that indicates we might want to look a little deeper with questions about autism spectrum. I did a little digging in the data. I'm sorry, not the data, in the literature, and found 2 studies that tried to look at Prader-Willi syndrome and autism spectrum disorder. So if you take that 26% and 12%, you average it together, it's about maybe 18, 19%. So maybe a fifth of folks with Prader-Willi syndrome are showing substantial symptoms where the clinicians thought it was okay to give that secondary diagnosis of autism spectrum disorder. So to summarize, with our data here, what we've learned is clearly, especially for the older kiddos, you can see we broke it down. There is an overlap between Prader-Willi syndrome and symptoms of autism spectrum disorder. It's been my experience that kiddos that we're diagnosing with autism have more substantial limitations. What we're still learning is, what do we do with this? Is there a benefit to adding autism spectrum disorder to a child with Prader-Willi syndrome? Could there potentially be more services, more funding, a second situation, or a second situation where the school district may do something different, add some therapies, those kinds of things. So that's the 3 data points that we've got. Cognitive development, looking at measures of externalizing and internalizing behavior, as well as symptoms of potentially autism spectrum disorder. We wanted to share this with you all as part of the research day, but we also wanted to share a story that, we do this work in a clinical setting. This is a clinic that serves patients and families. So I've asked Erin to pull out a case where having this data at hand and at the ready really assisted a particular family. So she's going to share this information with you guys right now.
So here we have an 18-year-old that has been with our clinic for a very long time. There are significant challenging behaviors or cultural factors, and there have been many systems involved with this family. Our clinic has recommended guardianship for the family. Without this process that we have, mom would have to go through it herself. It would probably be very difficult, and she'd have to go through wait lists and see a lot of different doctors. But since we do offer this service, mom was able to bring in her paperwork, and we were able to get the assessments finished. And now the family is one step closer to guardianship.
So we thought it was a nice example that we would share with the group that although this is presented in a research format, the data that we have has a real impact for some of the families. So in the remaining minutes, I want to take some time to try and summarize, again, what we've learned so far and what we are still learning. So here's our summary. Again, lessons learned. The first, and I think most important, is that this can be done. Erin and I have been able to pull this off. Obviously, having space and time helps. I like to use the phrase Tetris. It's almost like Tetris in our clinic. So Erin may start in room 5. I may move a child to room 6. She takes her kit and moves to room 3. And so all that bouncing around helps us pull this off. Our teammates are very flexible and understanding, and so are the families. So, and the first thing we've learned is that we can do this. You can do ongoing psychological and behavioral assessments in our clinic. The second, and maybe this is a bit bold, but psychological and behavioral assessments are just as routine as a blood pressure check or a weight check. So just a thought here, happy to share more, hear what more folks would think about this. Is this potentially a standard of care? Should we be able to do psychological and behavioral evaluations of this population as routine care for this population? I would argue it would be a good thing, but I'd love to hear more from other folks who are working in other centers and situations about their experiences with this. Obviously, adding help is helpful. So I've been part of the clinic for many years. I just kind of couldn't get my act together to pull this off. Erin was interested and has joined us. It's been very beneficial having an extra set of hands. Parents generally have been very supportive of this and positive, so have our teammates been. Now that Erin's been at the clinic for a few years, a few of the patients have been coming into clinic asking to see Erin because they want to play the games with Erin again. And so it's nice that the part of doing these evaluations is part of what happens when kids come to the clinic. And then finally, some real world impact for some of our patients with the data that we've been gathering. Okay, still learning things, of course. Do we have the right tools? Do we have a young child test we can use, like for infants? Is there an older child test that we should use? What are the best forms? We want forms that are obviously accessible to families. The CBCL is very long. It's about 100 questions, thinking of maybe scrapping that and trying something else. And again, can this data inform the medical decisions for the medical team? Again, what about a case where we assess a child, we start growth hormone, and then we reassess them? Are there any changes there? And like I said earlier, are there any referrals to other professionals because we've got this data? So in the few minutes that I think I have left, I want to share the team that we work with. So this is our group. As you can see, they're from lots of different disciplines. We all meet twice a month. It's very dedicated, wonderful, fantastic group that's open and welcoming to all who come into the clinic. And we can't, of course, go without sharing a picture of most of us. This isn't everybody. This is us with obviously our masks on, but everyone is vaccinated. So we decided to take a picture of us again with our masks off. So you can see our smiling faces. We're just outside where the clinic is located at the main campus at Children's here. It's a wonderful group to work with. So I want to leave time for questions, of course, and say thank you from both Aaron and I. Feel free, these are our emails, to shoot us any messages. We're happy to talk more with anyone present today. And I'll just say it's truly a privilege to be part of the Prader-Willi community. I've really enjoyed it professionally and personally. My boss came to me 10 years ago and said, there's a clinic that I think needs some help. Are you interested? I said, sure, what is it? He said, Prader-Willi syndrome. I said, I'm not sure what that is. I learned. And I learned from the parents and the practitioners I've been fortunate to work with. So it's really been a wonderful journey for me professionally and personally, and I'd wager Aaron too. So thank you for sharing your loved ones with us out there in the Prader-Willi community world. And we want to leave the last few minutes, I think, for any questions from folks present today. So I think I should stop share. Is that right?
You can do that, and then we can chat a little, and Dr. Poggi can join us as well. We have a few questions. I think wonderful presentation. Thanks so much. It's very interesting to see these kinds of behavioral assessments. I do think that we need to broaden our range of important testing beyond just trying to assess hyperphagia all the time. We have some questions here. What has been your experience with measures of adaptive functioning? This can be helpful in populations with low IQ scores.
Correct. We have not been doing adaptive function measurements in the clinic. Some of the standard ones that you would use, for example, the Vineland scale is a very common use scale. It takes a long time, honestly. If you were to sit and interview a family, depends on lots of factors, but you're probably looking at a half an hour to 45 minutes-ish. I mean, there's a possibility now that with electronic records, we can maybe, we thought about this, send a family that tool electronically in our medical record chart, which they can access electronically. They could fill it out, get it back to us beforehand. Aaron and I could share the results. That's something that we have been kicking around. It's actually been a unexpected benefit of COVID, right? Is being able to send some of those things to families beforehand instead of just in paper. But as it stands now, no, we're not doing an adaptive assessment measure. That's a good idea, though.
Have you looked at subpopulations based upon subtype or gender or other things?
Just a little bit. We really haven't dug really deeply into that yet, although I'm curious to that. We think of some of the data about behavioral challenges with UPD versus deletion. Again, Aaron and I haven't dug that deep yet into seeing are there any really significant differences, say, in challenging behavior with the two subtypes. But that certainly is an area we could elaborate on maybe for next time around. And I think that's been on my mind for sure.
Similar kinds of questions related to growth hormone and different factors that could be affecting potentially behavior.
Yes.
Activity. I know some kids are on testosterone, which certainly I don't know how much would that impact the behavioral assessment that you're doing. Probably not that much. Not
a ton. It's a fair question though. So far we have not dug really that deeply into the medications that kids are taking that we've been measuring. It's a great question. We could certainly review the files electronically and see of our 40, what are the dosages of growth hormone? When did they start to growth hormone? Those are all those factors. That's kind of the things yet to learn with this process.
Right. I mean, I think, the expansion is the interrelationship between all of these factors, but I think you got to have the behavioral data at the front end on a large sample to be able to do that. But I think that's terrific. But Dr. Poggi, do you have any input?
I think as you go, you're going to be seeing folks that have, medications introduced. And we had some discussion about, the cytochrome P450 system and, looking at how that might impact different behaviors and so on. And, I thought that the question about the functional assessment was a really good one. So.
Mm-hmm. Did you notice any differences with video learning and therapy during COVID?
We did a few clinics virtually. We didn't do any assessment during that time. I'd be honest, we didn't even think about it at the time because we were scrambling. In my practice, though, with kids with developmental disabilities, I'll be honest, it's a mixed bag. For some families that live in West Virginia, for example, it's a godsend. For other families who are having challenges with technology, it's rotten, to be honest. So it really depends. But I would argue that I think some level of telehealth should remain in this population, and certainly I would imagine lots of other populations too. So it's been a mixed bag, I'll be honest. But we are doing cases now back in clinic, and the families are coming in and seeing us as they used to before the pandemic.
Yeah, I would think for rare diseases as well, having the ability to not travel, because
Yes.
it may be hard to find specialists. And
Yep.
for anxious kids and stuff, sometimes they like being at home. It's sometimes
Yes.
the parents maybe that are having trouble with the technology.
Yeah.
But now one other question is, did you find that a concern about multiple evaluations fatiguing the patient or the family?
That's a great question. I mean, there are some families that, Erin would approach them with some of the forms. We had times where the forms didn't get done. And that's okay. We never pushed it. We weren't pushy about it. We said, we'll catch you next time. It's not a big deal. Some of our kids had a hard time in a structured testing session that Erin's doing. Some of the kids are little, and so they're busy and active and they're kind of grabby. But Erin did a great job of keeping them focused and getting some of the data. Again, it's just, most of these are screening tools. So we would never place like a major diagnosis based on an abbreviated cognitive measure. But we were approaching it as something small that we're gathering in the course of clinic.
And what age range would you start at? How young of a child would you begin?
Well, the Binet starts at 2, but that's a limitation because we have infants in our clinic. So I was thinking of the Bailey scales of infant development. It's a very common measure used for birth, I think 36 months. And so Erin and I would start playing with that, I think, soon. So we can even start seeing a 3-month-old and doing some information so we can track that kid for the first 2 years.
Fantastic. I think we're going to have to end it now, but thank you so much. Wonderful presentation. Really love to see the data, and we'll thank you so much for closing out our presentation portion. Take care.
Okay. Have a great day, everyone. Thanks.
Thank you.